There we go. Hey everybody, I'm NOWSKI, and in this video today I will be talking about a topic that a few people have asked me about, and that is the topic of, as a nurse in the hospital, what do you do when your patient is actively dying or has just died? So it's not the happiest subject to talk about, but it is very interesting. And I know as a new nurse and as a student nurse, this was something I really wanted to know about. And you don't really fully grasp it until you experience it in the hospital yourself. And I work in an ICU, a really busy, big ICU. And I have experienced patients passing away, both on the really urgent side, where we're doing everything we can to try to save them, to the other end of the patient passing away spectrum, where the patient or the family has decided that they want to withdraw care and basically pass away naturally. So it is a very interesting process. Can be crazy and unpleasant, but on the other end, it can be comfortable and beautiful, depending on how you see it. So to kind of start talking about this topic, I'll first talk about code status. Any patient that comes into the hospital has to have a code status on their file, on their electronic chart, where basically this is saying, what do you want us to do should your heart stop beating, should you start to die? And the options are that you might have a patient that is a full code. This is the patient that wants everything done. They want CPR, bag breathing. They can be put on the breathing machine if they need to be intubated and put on the breathing machine. They can be defibrillated, shocked. Basically, do everything you can to try to revive them and get them living again, keep them living. There's another option, which is a DNR. This is the patient who, it's a do not resuscitate, meaning keep treating them just like anyone else, but should their heart stop, should they go into cardiac arrest, they do not want to be revived. They don't want CPR. They don't want to be in the breathing machine or shocked. They just want us to let them pass away. So that might be a patient who is, very, very old, and they think, if you do CPR or, shock me, revive me, at that point, what's my quality of life going to be? I might just be stuck on a breathing machine. I might just have a bunch of broken ribs. It might not be very comfortable. And they might just want to pass away should it come to that point. Or maybe their disease process is very advanced and they also just don't see a quality of life that's very good should we even be able to revive them through CPR and things like that. That's the second code status option that a patient might have. And then there's another option, which at our hospital we call comfort care. You might hear it as palliative care. This is when a patient or the patient's family has decided they want to stop treatment and focus only on comfort. So it all comes down to keeping the patient comfortable, stopping all these interventions if they're on the breathing machine, withdrawing that, turning off all the drips and IVs that might be contributing to them staying alive, but they've realized that they just want to be comfortable. They know that things aren't getting better, so they just want that palliative care, that comfort care. So I've had patients in each of these category statuses that have passed away on me in the ICU. So I'll kind of talk about each type of patient and basically what the nurse does in that situation. The full code patient, say you have a 50-year-old man who's had a heart attack, has bad cardiovascular disease. He's a full code. You walk into your room, say you're on the floor where there's no monitor, you feel for a pulse, there's no pulse, he's not breathing. If you're in an ICU, it's nice because you do have monitors. You can actually see what rhythm he's in, and the alarms go off should he go into a lethal arrhythmia where he loses a pulse, or should he stop breathing. Alarms would go off then as well. But basically, you walk in, it's your patient, you activate the I don't know, they might have different names for it in different hospitals. Ours is the code stat response. So we hit a button on the wall, all the alarms and bells go off, and it announces that there's a code stat in this part of the hospital. And it seems like half the hospital runs there. So you get a bunch of doctors, a bunch of nurses, respiratory therapists, the pharmacist, if there's CNAs, if you're on the floor, basically a lot of people show up. So you're not going to be alone for very long. But if you are the first one there, biggest thing, you jump on and you start doing compressions. You start the CPR process. So if another person gets there, you want to start doing the bag mask breathing for the patient. Because this could start as a respiratory arrest. If they stop breathing, it's not going to be long before their heart stops beating. If you don't breathe, your heart stops and you die. So regardless, you activate this code response system and you start the CPR process. If you are ACLS certified, which if you're a new nurse or a student nurse, you'll know what that means. You'll take a class and you learn what you do. You can either do basic life support or advanced cardiac life support. So in order to lead a code, you either have to be an ACLS certified nurse or you have to be a doctor. And basically there will be that person leading the code. There will be nurses handing medicines out of the crash cart to other nurses who push the medicine. There will be another nurse who's documenting what's going on. There will be, what am I missing? A nurse or what will end up being a respiratory therapist who gets on the bag breathing for the patient. Eventually you might have a doctor or a CRNA come in and they might intubate the patient so that when you're not just bag mask breathing for the patient, they might put a tube in so it goes directly, all that air is going into the lungs rather than with the mask, you're actually pushing air into the stomach and into the lungs. So it's not as effective. So they might intubate the patient if the code is going on long enough where they think they need to jump in and do that. So this is a full code response when your patient is actively dying. A lot's going on, everybody's showing up, and it's it can be pretty exciting. It gets your adrenaline rushing. As the nurse, you basically just have to think through what you're doing. You're doing CPR, you're doing this ACLS response. And, once you do it enough times, you know what you're doing. You're not going to freak out. The first time it happens, it's pretty freaky. And you might freak out. And if you are the primary nurse, you're not really taking one of those ACLS roles. You're standing back and you're going to be updating the doctor. What was going on? What was the patient? When were they last seen normal? What were they doing? What did they look like? What was going on when you found them with no pulse? So, and once they're on a monitor and everything, you'll get to see what rhythm they're in and go from there, whether you're shocking the patient's heart or you're just doing CPR and pushing epi, things like that. So if you haven't learned all that, you'll get to that point if you're still in nursing school. And I really enjoyed learning all that, but I think I could ramble on about that for a long time. It's a very interesting process. But anyways, so that would be the response to a person who is a full code who starts to pass away. The next person I'll talk about is the DNR patient. So if you have a DNR patient and you walk in the room, this is the patient that does not want to be resuscitated. They have no pulse. They're in a lethal arrhythmia. They're not breathing. This is going to be different. You're not activating the code response. You are calling the doctor. You're telling other nurses on your floor, hey, my patient's not breathing. There's no pulse. You are letting the family know that the patient no longer has a pulse. You'll get, a doctor there. You'll probably get them on a monitor to see what rhythm they're in, what's going on, if they're not already in the ICU. I've only seen this from the ICU perspective. I've never worked on the floor, so I'm assuming they would still bring a monitor in, put the patient on a monitor just to see what lethal arrhythmia they're in. I would assume. I'm not exactly sure, but basically you're getting the family there. You're letting them be with the patient for their final moments. And then once the patient has no electrical activity in their heart at all, the doctor will call time of death. If the patient seems uncomfortable at all, sometimes if you're going, if they're in a lethal cardiac arrhythmia, but they might still have these gasping breaths. So if the patient looks uncomfortable at all, the doctor will give comfort meds, pain meds. Usually it's morphine. So that is your do not resuscitate patient. The other type of patient would be your comfort care, your palliative care patient. This is the patient where the family or the patient themselves, if they're still, with it, if they're not, in a coma or something like that, they've made the decision to withdraw care, and we're just there to keep the patient comfortable at that point. So as the nurse, they could be, you could have a patient that's been a full code, and then the family decided to switch them to a DNR, or the patient themselves made that decision. And then they might have decided, hey, let's just do comfort care. We've been in the hospital forever, nothing's working. At that point, we're just going to keep them comfortable. So at that point, if there are like active drips going in, we're turning those off. We are, we're not going to be checking blood sugars anymore. We're not going to be giving the patient medicines. We can take out, if they have like an NG tube, OG tube, all this, that can come out. If they are on the ventilator, the breathing machine, that would also be turned off or come out, be turned off and the tube actually taken out of their mouth. And often when that happens, the patient will pass away rather quickly. At least the majority of the time, if they're very dependent on the ventilator. So at that point, you'll want the family there with them. The ventilator's turned off. Sometimes the patient, they will breathe on their own for a while. Other times, within 1 minute, the patient, has stopped breathing and, has gone into a lethal arrhythmia and passes away. So at this point, as the nurse, the whole job for you is to keep the patient comfortable. Doctors usually order morphine and Ativan, so it's an anti-anxiety medicine and a pain medicine, or some combination of these medicines, and you can give those like every 15 minutes as needed IV. So the patient is kept super comfortable throughout the whole process. And that's basically what you do as the nurse. You're watching for this. You're watching for any signs of discomfort, whether it be the patient gasping for breath or grimacing or showing some signs of anxiety. We don't want any of that. So we're just there to keep them comfortable. So that is a comfort care patient, a palliative care patient. Sometimes, if that patient, you can be on palliative care for a long time. It's not always like immediately the patient passes away. So they may actually move them to a palliative care house outside of the hospital. They may, move them to an area of the hospital, the palliative care floor, if they're in the ICU or, on a med-surg floor or something like that, and they've decided to go for comfort care. So you see both patients that pass away really quickly, and then patients who don't. They move to a new place, outside of, the ICU or the med-surg floor, to a place that's very comfortable, where all they focus on is comfort and letting the family be around the patient and things like that. So those are your three main types of patients. Eventually, if the patient does pass away and you're there in the room, I usually let the family have their time. I don't go piping in, don't go saying a bunch of stuff. Let the family have their moment. Your job is to be there should they need you. Don't say things like, well, at least this, at least you got to see them before they died, or things like that. Don't say don't start anything with at least this, or don't say things like it'll be okay. Basically, just shut up and don't talk. But you can say, like, I'm sorry for your loss. You can say things like, I'm I think it's wonderful that you were there for the patient at this time. Just don't go putting in an opinion or anything like that when you're talking to the family. But, as nurses, it gets to that point where, okay, the patient's passed away, the family's in there. The family's going to feel kind of awkward. They don't know what happens next. So you do need to kind of jump in as the nurse and say, okay, this is what's going to happen next. You give them as much time as they want with their family member who has passed away. And then you're going to say, okay, like at our hospital, one of the nursing supervisors, house supervisors will come up and talk with them about making arrangements. Don't just leave them in there forever. They don't know what to do. They're all just standing around and, they want to know like what's going to happen now. So that is what happens. Usually some sort of supervisor will go in and talk about making arrangements for getting the patient to a funeral home or transporting them off of our unit to the morgue. And then, from there, a funeral home can come, pick up the body. I know this is a really weird subject to talk about, so hopefully everyone watching this video is nurses, because I talk about it on the nurse side of things, but this is what happens. So once the family has left the room, you, as the nurse, you actually do postmortem care. So you will kind of clean up the patient. You'll take out IVs. You'll take anything out, if they have electrodes on the patient's body, things like that. So you'll take basically everything off, and then you will place the patient in some sort of bag. You will put the patient into a body bag, and then you will either a funeral home will come pick up the body, or the body will go down to the morgue. But that's what happens. So the first time you do it, it is going to be freaky. It's going to be weird. You're going to be anxious and all that. Once you do it a lot, you get used to it. You just kind of do. And that is that. So that's postmortem care, which you will do as a nurse, at least in the ICU. I've done it a lot. That's what we do. So you end up putting them in the body bag and getting them to where they need to go. And then you chart. You chart about everything that happened and everything like that. The doctor will fill out a time of death certificate, everything like that. So I hope this kind of gives somewhat of a picture of what goes on. I'm saying this as I'm thinking of it. I always tell myself I should probably write things down, and I don't know, maybe that would make the video not so long. I'd get right to the point. But that is what it's like to have a patient who's dying or has just died. You got your full code where you do everything. It's kind of crazy. You're activating ACLS along with anything else. So if they're bleeding or something, you might be giving them blood, giving them medicines, get their blood pressure up. All that's going on with your full code, your DNR. You're basically realizing, okay, they're passing away, getting the family there with them, getting the doctor there to know what's going on, and then you let them pass away. With the comfort care patient, you are keeping them comfortable, and they could pass away very quickly, or they, might not, and they might actually leave your floor or your unit to go to a palliative care area. And then postmortem care, you are, if the patient does pass away, you are cleaning up the body, taking out IVs, taking off stickers and drains and things like that. And you put them in a body bag and move them to where they need to go. And at the same time, you're talking to the family only in a supportive role where, you're saying that you're sorry. If they need anything, you're there for them. You're not giving any opinions or making any judgments about anything, and you're letting them have time as a family in there. It can be sad. I want to say, I've probably teared up a good bit, but I'm so focused on my role where there's a lot of things to do that I try not to get too attached, where I do my job, and you kind of get, I hate to say it, but you kind of get used to it, and you let the family have their moment. You keep doing your job, and you still be sympathetic and supportive, but you're usually not in there bawling your head off. I mean, this is their family member. Let them grieve. You've got more work to do, and you probably have more patience that you also need to get to. So eventually, at first it might be hard to do that, but you get to the point where you can handle it, and it can be to see people leave this earth can be humbling, and it can be a beautiful experience to actually be there with them at their final moments. Because then you might have a patient where there's no family shows up, they don't have any family, it could be a homeless person, and you get to be you and maybe a couple other nurses, a doctor, could be the only ones in there with them as they are, breathing their final breaths, having their final heartbeats. So it's a privilege to be with people in those situations, and it's very interesting. So I hope this helps. If you've ever wondered about what goes on, and I hope I didn't ramble too much. I hope I hit everything that I meant to talk about. This video is posted on YouTube, so if you have any questions or want to say anything, leave comments down below. Don't give me specific stories about, specific patients or anything like that, HIPAA and all that. So, but if you want to talk about anything related to this topic in the comments section, feel free to subscribe. I talk about nursing stuff from time to time, and I will see you guys next time when I talk about something else. Okay, bye-bye.